Hello and welcome to episode 10 in the Colorectal Live series from Johnson & Johnson Institute and Ethicon. I'm Richard Brady, consultant colorectal surgeon at Newcastle Hospitals. And firstly, thanks to everyone who's been joining us along our journey to date. You can catch up with all of our previous insights on our new landing website at jnjmedicaldevices.com, and the address is on your screen right now. Now, tonight's episode is all about Dr. Debbie Keller. Dr. Keller is one of the world's most collaborative, connected and impactful colorectal surgeons with a massive online influence. She's a clinical assistant professor at the University of California, Davis, a surgical scientist, and specialises in pelvic surgery and colorectal and rectal cancer clinically. Now, Debbie holds an assistant editorship with the Colorectal Disease Journal, Diseases of the Colon and Rectum, and is editor-at-large with Techniques in Coloproctology. Tonight, Debbie will be telling us all about her career in research and her journey to date, and will be specialising on clinical optimisation and outcomes, technology innovations, and burnout. So, thank you very much for joining us tonight, Debbie.
Oh, thank you for the opportunity. I'm thrilled to be here.
And remember, you can get engaged in the conversation too. You can ask your questions directly to Debbie using the hashtag ColorectalLIVE on Twitter or elsewhere, and you can get engaged also on our Twitter polls, which will be coming up shortly through our interview. Now, Debbie, let's get to know you a little bit better. You're a consultant colorectal surgeon and a assistant professor of surgery. Did you always want to be a surgeon?
Always. I remember when I was 9 being in the hospital after surgery and being woken up by what I understand now were medical students, then residents, then fellows coming in and ripping off bandages, pushing on incisions, and then walking out to me. And I told my doctor that I didn't want people coming in the room other than him. And he challenged me. He said, I need to let them do their job, but what I can do when I grow up is do what they do and just be better than them. And, I've carried that with me through my whole career. That immature conversation has really led career in surgery.
So, Debbie, that sounds like a pretty traumatic start to a career in surgery. What were the key moments in that journey, and who was around there to impact that direction at that point?
Sure. I've had amazing people in my life. I actually did my residency where my surgeon was and really affirmed my love for colorectal surgery during that training. I had very strong female leadership from my program director, Dr. Amy Goldberg, who's now the chair there. She taught me to be bold and to be myself. Mark Seaman, who was one of the trauma surgeons and actually introduced me to research during residency, one of my earliest and still favorite mentors. I met Dr. Connor Delaney as a resident, and he flipped a light switch on for me, helping me to realize my own interests. Being his research fellow after residency shaped me as a minimally invasive surgeon and an enhanced recovery researcher. The amazing Tracy Hull during fellowship. She's the epitome of a great surgeon, person, and patient advocate. I still model myself after her and turn to her for help. And then key moments in people after training came from taking chances and reaching out to people that I thought were brilliant and wanted to learn from. Steve Wexner for everything, John Marks and Eric Haas for advanced minimally invasive surgery, coming to London to work with, Gina Brown and Manish and Richard. And more doors have opened from taking chances. And it shows that mentors don't have to be at your own institution to shape you.
Well, Debbie, I guess if you're going to have mentors and sponsors, you might as well have a who of the most famous people in colorectal surgery. I'm sure that doesn't harm you at all. But it sounds like you had major mentors and sponsors as you progressed through your career. How important is that, and how do you make a difference between those two very important groups of people?
I think it's critical. It may be the most important thing. And you should have many mentors at all stages of your career to address everything that you're going through. Mentors are a sounding board that are going to give you critical advice and help shape your decision-making. They really enable you to become the best version of yourself. They're usually less senior than sponsors, as it's a time commitment and a long-term relationship. Sponsors are more well-established and connected leaders that use their power for good, helping you to connect, meet people, have places and opportunities to move yourself forward. So essentially, mentors advise and sponsors actively push you forward.
Now, Debbie, we've all been through a terrible year. And it can't have escaped anyone's notice that pandemic COVID-19 has had such a major effect on all our lives. It's also very disappointing to see a recent uptake in some countries that have been distributing the vaccine program. But can you tell me, I mean, I understand you were right at the eye of the storm in New York when the COVID pandemic hit. What was it like being a surgeon in that environment, and how did it affect you personally and your colleagues?
It was physically and emotionally draining. We are doctors, not just surgeons. So our response is to help. We volunteer, we give 100%. But this was nothing like anyone has ever seen. By the end of March, most elective cases were stopped, and our hospital became a COVID center, converting all ICUs, operating rooms, and common spaces into COVID ICUs. The capacity was more than doubled, and most patients were COVID patients, intubated, and critically ill. We were all reassigned working shifts where every day was pretty much the same, just death and fear and isolation. And we carry that with us. We still do. And we were also isolated and scared and lonely. I got pretty sick myself, was able to be home. So relatively no complaints there.
So clearly a really traumatizing time for you personally, very isolating, I think, professionally for most of us in the specialty. Looking back, what were the big main lessons? What should we do differently next time?
I think that we need to respond faster and in a more centralized fashion, and constant, open, honest communication and protection for your providers, not just your patients and your earnings.
Now, Debbie, you've recently moved to California, and apart from a change in climate, clearly there will be a change in time given the pandemic has now maximally passed in that area. How has your practice changed on a daily basis? How has your interaction with patients changed?
It hasn't changed very much here. Despite numbers, we're not very affected by the pandemic. It's pretty well controlled. One change that we do see is still the increase in the number of telehealth visits, which is really beneficial for both patients and providers. But we're still operating at full capacity.
Right, Debbie, I want to explore the second victim syndrome. It's a situation which is really common in surgery and affects surgeons worldwide. What is it, and how can we avoid it?
Second victims is essentially when, after a complication or a mortality, the surgeon becomes the victim, traumatized by what has happened. And they carry that with them, feeling despondent, guilty, fearful. It can impact their daily lives. It can impact their professional life and their desire to operate. And it can also lead to burnout and leaving the field, as well as high rates of suicide and depression. I think that in the current environment, having complications is punitive. Clearly, none of us want complications, but learning from them in a constructive way instead of the guilt that we carry and can't let go of from having complications is something that can be changed.
Now, Debbie, is there ever a healthy way of dealing with complications? And can you give us some advice as to what you advise maybe your juniors when they have a complication?
Sure, absolutely. We all need to face them. You know, it was told to me by Steve Wexner that you know that you're operating enough when you're having complications. So although it's nothing that anyone wants, it's almost good to have them. They are an excellent technical learning opportunity. And I think that we need to get the technical and quality factors off of that. But aside from anything that happens at a quality review or a morbidity or mortality conference, it's not making it punitive, it's making it for quality improvement. And after learning from that, it's making sure that you can move on. And, you know, the initial reflex is to not want to operate, to not want to make the same mistake twice. Obviously, if you knew what you did, you wouldn't have done it in the first place. So I don't want to operate. I don't want to go back into the operating room. I don't want to take care of patients. And what I was told is you need to do it more. You need to take extra call. You need to take extra shifts. You need to get back on the horse. You need to not avoid the patient that you had this complication with. You need to develop a stronger tie with them. And that was really excellent advice. And one of the other things that we've done here at this institution to make sure that this isn't something that's perceived as being punitive is anyone that is new in practice in the first or second year, when they have a major morbidity or mortality, is to speak to them one-on-one outside of any formalized session and go through both the steps and the emotion associated with it to make sure that they have the ability and the guidance to move on from it and learn in a productive fashion.
Debbie, I'm really enjoying this conversation, and these are some really interesting and really dramatic insights into the kind of experiences you have been through, especially more recently. And now I want to turn to our viewers live. We come to the first poll of the evening, and we're going to ask them about their situation and their feelings about burnout. So please get involved with the polls right here on J&J Medical Devices UK&I Twitter feed. And here's the question. What is your experience with burnout currently? Are you suffering with burnout? Are you likely to suffer burnout this year? You're not suffering burnout but might in the future, and unlikely to suffer burnout in the future. And we'll give you the results of that poll very shortly. Now, Debbie, many of the factors that we're talking about tonight are affecting retention rates both in the UK, US and elsewhere in relation to surgeons, and burnout rates are documented as somewhat incredible. Can you give us any insights into how you personally have addressed burnout, or what kind of advice that you give, again, your juniors in relation to dealing with the issues surrounding this pandemic amongst surgeons?
Not just for burnout specifically, but in general, to have strong relationships with your mentors, because they really create a net to help catch you when you suffer from things like this and could be falling in a downward spiral. From burnout specifically, talking to someone senior, working through those emotions, and also to be able to shut off and to have things outside of the hospital, reconnecting with the things that bring you joy, past issues, past hobbies, things that make you happy other than surgery, so that you have a fully developed life and you don't live or die versus what happens every day in the hospital.
Right, Debbie, moving slightly in terms of subject, you're now in a great academic role within California, and I think we'd like to know, why did you make that decision? Why move from New York to California?
It was really for the people and the opportunity. What I learned at my prior post is no matter how hard you work and what you accomplish, if you and your chief are not aligned in your vision for the future, it's not sustainable. I am aligned with my chief here, Elizabeth Raskin, and have been encouraged and inspired by her since we met years ago. She was at University of Minnesota and led robotic training courses that I took. And I said at that time, if I ever had the opportunity, I would love to work from her. And we kept in touch. She's always pushed me to do the hard things, the hard cases that I love, to be an innovator, and to say no to the people in our profession that will suck up your time and your work products without reprisal or sponsorship. So being here with her has really given me great opportunity to do these cases and to explore my research and explore my desires to create medtech and do surgical education. It's been a great environment. And no complaints about the weather.
Absolutely. And those key aspects of teamwork and a unanimity of goal are so important to a happy department of surgery. Now, you've clearly started off in a surgical research role very early in your career. What was the origins of that? And can you tell us some stories about what it was that actually made you want to become an academic?
Sure. And you'll laugh that I didn't really start very early. And in fact, I wasn't interested at all in research when I was going into residency. In the United States, they have programs that have designated 1 to 2 year research requirements. And I specifically didn't choose those programs. I was engaged by Dr. Seaman, who was a trauma surgeon in my residency program, after a patient encounter left me with questions to look more into it. This was a learning experience of designing and carrying out a study. We looked at the long-term outcomes of emergency department thoracotomy survivors, interviewing patients, assessing quality of life, function, and pain. And the results were jarring. For providers that we were patting ourselves on the back for all of these amazing saves, our patients had high rates of suicide, depression, substance abuse, and chronic pain with poor quality of life. So from this, we were able to put a survivorship program in place. And that is health services research. Seeing the difference that we made, I've been hooked since. And research really offers a way of making an impact past the one patient you're operating on. I love the collaboration. I love the teamwork. And it can offer you an escape to work with people outside of your little assigned box, which is really helpful if your box is not supportive. So you have the ability to change the patient's outcome. It's really the maturation of my childhood promise. I'm doing it better with research.
It seems to be a theme that has come through the entirety of your life, which is really an impressive methodology. Now, Debbie, tell us about the US research training system and scheme and an ecosystem. I mean, for a global audience, what is it like to do research in the US?
There is less importance placed on research than it is globally, especially in the UK, especially with what I saw. I think that it's terribly undervalued and poorly organized. There are select centers where training is well established, and then there's support for funding there. So trainees can secure federal extramural funding, go into a lab, and get that vital experience and mentorship to develop. But that's not the norm. For most, it's a frustrating experience. There's struggles not with the experimental side and results, but with the logistics of actually securing a spot, securing a salary, where to find data, and how to get support for your work. And that lasts even into practice here. I literally run randomized control trials with one fellow. So I can say you have it very good with your centralized NIHR and CTUs in the UK.
Right, while we're on the subject, Debbie, can you tell me about your current research programs? What is it that you're exploring at present, and are there any findings that you've been particularly proud of during your career?
Sure. The four broad categories that I'm working in are next generation enhanced recovery, which covers our recover quality improvement programs, rehabilitation, optimizing care of the elderly, and opioid reductions, rectal cancer standards, cancer disparities, and surgical education. I am very proud of the recover work. For most institutions that have some sort of enhanced recovery program in place, you stabilize length of stay first. That's low-hanging fruit. Recover is literally reducing the costs, complications, and variability with enhanced recovery. So we have seen marked improvement in the patient stay, the hospital costs coming with that, and greater understanding and patient education of the surgical process.
Well, on that note, we've now reached the time for our second Twitter poll of the evening, and I encourage you all watching to vote on the poll on J&J Medical Devices UK and I Twitter feed. The question is, do your patients have access to formal ERAS program and support? Answer number 1 is yes, number 2, no, and number 3, in development. And we'll check out your responses at the end of this very interesting program tonight. Now, Debbie, can you also tell me a little bit about your fascinating work in hospital design?
Yes. From my own experiences as a patient and from a provider, hospitals are not designed well for patient recovery. We know that patients need to be up, they need to be ambulating, they need to have that position of gravity moving downward for them to have their function back and their motility back. And that is not what happens when patients are in classically designed hospitals. They sit in their room for about 23 hours a day, just waiting for the provider to come in, which is usually once in the morning and once in the evening, other than the nurses coming in and out. So having the ability to bring patients out was something that was very exciting here, and it's still something that's in development. But working with our rehabilitation physical therapists and PM&R doctors, we have designed an exercise program that patients can do both standing as they walk through the halls and have the support bar on the wall, and sitting in the sitting sections, so that as they move through, there are 18 exercises on the wall that will put them to a 25 to 30 minute exercise program. And I think that that's pretty exciting. And we also have walking tracks with 2 different colors for the different sides of the floor and markers along the floor so people will know how far they've walked. And we've designed some gaming incentives into that to get people up and moving and motivated.
Right, Debbie, in addition to all of that, you've also got an interest in medical technology. Can you tell us about some of the work that you're engaged in, and also how is it changing surgical delivery or education?
Sure. And it's funny that it literally took a pandemic to make some of these medical devices accessible to everyone. It's especially changing surgical education and patient care. Using specific apps and virtual reality modules, we've had the ability to both monitor patients and educate them at their own speed, taking them through the actual surgical process and what they experience and what they can experience in order to better engage them in their care, which will make them more willing to follow our instructions and work towards the common goals. For surgical education, the apps and the modules have been brilliant so that surgeons can do their own performance improvement. They can use them for cognitive learning before surgery, the pre-training section. They can use them to record their outcomes with the actual cases and feedback that they're getting during the case, and then go through that in the post-training evaluation. So it's not just improving their technical skills, but also their cognitive skills, their communication, and doing it in a real-time fashion. So I think that these are amazing benefits that we're getting with new tech, and I'm very excited to be developing them.
Absolutely. I mean, the entire field sounds incredible, and I think your work in it is so important. Now, Debbie, let's focus on your work within publishing. And for our general audience, you're obviously sitting on many boards across the world in multiple different journals. What is it that you're hearing at board level that is the next big thing in terms of surgical publishing?
I think that the next big thing is going to be an immersive experience for publishing. Obviously, people are looking for more open access for journals and for participants to read and to use the different senses, looking at videos and podcasts and virtual abstracts and visual abstracts instead of just the printed word. But giving people the immersive experience so that they can interact with the authors themselves and become almost part of the experiment in the results is going to be exciting.
Now, Debbie, many of us worry about the current market in relation to publishing journals. Do you think the current model will survive?
No. I think that the content will survive, but the form absolutely will not. And we'll always need the impeccable taste of editors like Neil Smart and Susan Glanjak to show us what's important and to curate the articles to go into the journal. But we are not going to be waiting by the mailbox for the monthly hard copy edition to come out.
Now, as an assistant editor, you obviously have an insight into the kind of papers that are crossing your desk and are being discussed at boards. What is hot and what is not in the world of colorectal publishing currently, and what would you advise us to get engaged in?
So this will vary a little bit journal to journal, but I can say that what's hot is artificial intelligence, machine learning, convoluted neural network modeling papers, early onset colorectal cancer, especially looking at epigenetic and local tumor microenvironments, population-based large-scale prospective studies, Damascus, and fit screening, especially as we're looking to increase our screening numbers in the last year. As an editor, I have to say I'd really love to see more quality studies on pelvic floor, but I know funding is difficult in this field. Things that are not hot, bowel prep papers, papers on stenting versus diversion in malignant obstruction, meta-analyses just for the sake of meta-analyses and publishing something, and any single center's take on COVID. Not hot. But for the most part, if you have a novel question and it's answered with clear methodology and the paper's interesting to read and likely to be cited, get published. Best publishing advice I got was from Winter, who's the editor-in-chief of BJS, who told me after getting something rejected that every paper has a home and just be persistent. You know, if it's novel, if it's enjoyable to read, if it's likely to be cited, it's going to get published.
Well, some great insights there, Debbie, at the top table. And also, I think you're absolutely right. Any more COVID papers and we might all just go a little bit crazy. So thank you very much for that advice. Now, Debbie, you've offered us some truly incredible insights and have a remarkable body of work behind you. So thank you very much for being my special guest this month. But it doesn't end quite there. Of course, we've come to the part of the interview that I'm sure you're most eagerly anticipating, I'm sure, for many months, our quick fire questions. One sentence answers only, please, and cue the music. Now, Debbie, what has been your single best day at work?
Doing the first TATME at the institution that went great, and come out of the OR to learn my mentee had her first paper accepted.
Fabulous day. And what about your single worst day at work?
COVID COVID unit cross coverage, putting a colleague onto ECMO.
Who inspires you?
My cancer patients. They're fighters and survivors.
What's your favorite saying or wisdom?
Only thing worse than being blind, having sight and no vision. Helen Keller.
What's the worst piece of advice you've ever been given?
To just keep my mouth shut, smile, and look pretty.
Well, what is the kind of books that you read, and what's your favorite authors or genre?
I read biographies and nonfiction, and I read and reread the classics. Favorite authors, Wharton, Fitzgerald, and Hemingway. And my favorite book is The Sun Also Rises.
How do you switch off?
Phone goes on silent, and then I run, I paint, I spend time with the dog or friends outside of medicine, just chasing down great coffee, wine, or live music.
What would you like to be most known for?
Improving the experience of surgical care for patients.
What question should we have asked?
It's interesting. I think the questions that I ask to get to know people are, what do you collect? Or what 3 people would you have over for dinner if you could invite anyone?
Great. Well, we'll include those next time, and I'm sorry that we'll never know the answers to those, Debbie. Just to repeat an earlier question which cut out from your transmission, what's your favorite saying or wisdom?
The only thing worse than being blind is having sight and no vision.
Now, thank you very much, Debbie. Those answers were fantastic. Now we are approaching the end of our chat, and I wanted to review our polls from earlier on in the voting tonight. So poll number 1 was, what is your experience with burnout currently? And what we can see in terms of the results are that 8% said I'm unlikely to suffer burnout, 23% said I'm not suffering burnout but might in the future, 33% said I'm not suffering burnout but likely to this year, and 36% said I am suffering burnout now. So what's your thoughts on those answers, Debbie?
I think that this is a call to action to change the systems that we're working in.
Absolutely, and I know that you are engaged globally in some of the calls to action and doing amazing work, if I may say so myself. Now, do your patients have access to formal ERAS programs? And support was the answer, the poll that we asked for our second poll of the night. And the answers were 62% said yes, 31% said no, and 7% said in development. Any opinions on that poll, Debbie?
Yeah, I think it's interesting because when you ask most people or surgeons, they will think that they have a formal ERAS program or enhanced recovery protocol in place, but they really don't have something end-to-end that supports patients. And something that we're working on is greater patient engagement and support through new tech.
Great. Now, Debbie, as a final treat, you are a well-known dog lover and actively promote your dog, Waffle. And I know he has his own Instagram page, so potentially you could be considered his sponsor/mentor. You'll have to decide which. Can you tell us what's the background to Waffle and why is it important for surgeons to have pets?
Sure. I actually got Waffle for my brother. My older brother was my rock. He was a senior vice president at CNN and essentially took care of me. And he was in a traumatic car accident a few years ago and had brain injury and spinal cord injury that has changed all of our lives. And after coming through the initial surgeries and rehabs and getting most of his function back, he's not working and was very depressed. And getting the dog was a way for him to connect again, to have a reason to get out of bed, to have something to focus on and something to take care of, and something essentially that saved his life. And honestly, the dog saved all of our lives. And I think it's so important for everyone in medicine and really everyone to have something that loves you and depends on you unconditionally. And how do you turn off? I don't even look at my phone or my email or think about what to do when I'm with the dog. It's just happiness. It's joy.
Well, Debbie, it's been an absolutely fascinating insight, and can I just thank you so much for inviting us into your background, your story, and of course, all of these stories have been so well put across and so touching. It's been really great for you to spend time with us tonight, so thank you very much, Debbie.
Thank you so much.
Now, I'll be back with Colorectal Live again soon when we'll be joined by Professor Julio Mayo, Professor of Surgery and Chief Medical and Innovation Officer at Complutense University in Madrid, and he's Medical Director of the Clinical Hospital in San Carlo. He'll be discussing his specialist subject, for which we all know him, excellence in networking. Keep following us here on Twitter for more information in the meantime, and remember, you can catch up with all of our previous episodes, including soon this episode, on our new website at jnjmedicaldevices.com. The address is on the screen now. Thank you again to all of our audience live for watching tonight's Colorectal Live.